Hey, welcome to another hallway interview from STS 2025 here in Los Angeles. I'm Emily Farkas, CTSNet Senior Editor, and we are joined with Dr. Dominique Vervoort, who is a tour de force in many ways, but in global cardiac surgery. I'm going to read your initials here. So MD, MPH, CPH, MBA, PhD candidate. Or am I missing any?
Not that I'm aware of.
MVP. Let me ask off the record, how do you have the energy to tackle all of these things that you tackle in all of your research and all of your global surgical efforts?
Yeah, thank you for the kind words. So I'm in the bit of a luxury position that I'm not currently doing clinical training. So I'm kind of in between periods of clinical training in my life. So I'm able to dedicate more academic and policy time to my, global surgical and global cardiac surgical efforts. But most of my work or most of my degrees have been focused on different aspects of the global surgical puzzle, whether it's healthcare leadership and policy, whether it's research on the ground. And all of these have slowly kind of been coming together as different pieces to the puzzle to hopefully support me in my future clinical training as well.
Amazing. Well, this weekend you're going to be talking on the global cardiac surgical workforce and how do we meet those needs. So if you were to kind of pick out 2 or 3 points that you think are most important from your presentation, where would you start?
Yeah, so I think we're all very well aware that there's major shortages in the global cardiac surgical workforce, and roughly they come down to the fact that we have shortages, we have an uneven distribution, there's a scarcity of training programs, there's a scarcity of resources, and there's still attrition and burnout within the system, resulting either attrition domestically or brain drain to other places. I would say from my talk and kind of some of the aspects that I will be covering, the main points would be more the workforce shortages in itself and what we need to do to actually address those shortages. So kind of a key number that I will want to highlight is the fact that amongst all the cardiac surgeons that we have across the globe, about 7.15 cardiac surgeons per million population reside in high-income countries. Low-income countries have about 0.04 cardiac surgeons per million population. So we see a difference of about 140 factor in density of cardiac surgeons per million population. This is despite the fact that disease burdens are somewhat higher in high-income countries, but definitely not to the factor of 140. And so something that we definitely need to address from a health systems perspective.
And it hasn't changed, has it, in many years? I saw one of your slides that sort of pointed out there's been no real moving of the needle, so to speak, right?
Correct, yes, especially when we look at cardiac centers then. So we don't really have longitudinal data for the workforce, but from a cardiac center perspective, back in the 1990s, an estimate was put out that there were about 0.7 cardiac centers per million population. When we looked at it again in 2023, it was 0.73, so 0.03 per million population more. I have to note that this is about 2,000 cardiac centers globally that have been set up in those years, in those 3 decades. But population growth is happening so rapidly that we're really not keeping up with that pace.
And do you think that the female representation in the global cardiac workforce is part of the problem here?
It's definitely a big part of the problem. So we recently looked at the representation of women in cardiac surgery and found that about 8% of surgeons are women, which is a very low number.
Globally?
Globally, yeah. When we look at the distribution by country income group, so looking at low, middle, and high income countries, we see that the highest numbers are in high income countries. But we also see that many countries, especially lower on the income group, have sometimes even 0 women cardiac surgeons in their population. So this is a really big untapped part of the population that could be part of the workforce. There's also increasing evidence that women cardiac surgeons have just as equal and sometimes even better outcomes as male surgeons. And also from a diversity in terms of our patient population, it's important to ensure gender concordance as well. So there's still a lot of work that needs to be done in terms of absolute numbers, but also definitely in terms of representation.
So what else can we do to build the workforce and to address these capacity issues?
Yeah, so I think it all eventually comes down to health systems in itself. As important as it is to set up individual training programs or set up individual short-term courses for surgeons, we ultimately need to have health systems that are conducive for having surgeons operate in different settings. If a health system is not capable of setting up a cardiac center or be able to provide the resources for surgeons to return to their country after training, then it's hard for surgeons to actually operate and be able to impactful on the ground. So I think first and foremost, there's need for political buy-in to have the resource, to have the training programs, but also to have kind of a supportive network for surgeons to be able to operate in, and obviously for patients to be able to seek care, which is where it starts. But I think a big part of what has led to a lack of political prioritization of cardiac surgery at the global level is misperceptions and inconsistencies in messaging from the cardiovascular community towards policymakers and towards funders, where they might not see cardiac surgery as a priority, but also that there is just too insufficient data with regards to the needs, with regards to the opportunities and the pathways to ensuring the establishment of cardiac surgical centers. And I think for us as clinicians, as researchers, as a cardiovascular community, it's really paramount that we work on getting that data and then ensuring that we have the right ways of bringing that message to those people in power who can make that change.
Well, that's been your mission, hasn't it?
Yeah, I've been trying to.
Yeah, absolutely. And I noticed that you took the World Health Organization's sort of target initiatives for 2030 for surgery and anesthesia and sort of tailored those to what we should be doing for cardiac surgery, right? By 2040 is what you were targeting. What would be the most important points there?
Yeah, so this is kind of a rework of the targets that were set by the Lancet Commission on Global Surgery, which was released back in 2015, and really tries to make sure that health systems are able to do any type of essential surgical care in a way that is accessible for the majority of the country's population. Now, extending from that, we need to have certain targets as well for the cardiac surgical capacity, including workforce. And related to my talk, then I would say one of the key figures with there to be ensuring that we reach a minimum number of surgeons per population. In this case, it would be about 3 cardiac surgeons per million population that we propose. But at the same time, some of the other recommendations relate to minimum volumes that we need across the population to meet surgical needs. We need to think about financial risk protection, we need to think about tracking data and so forth. So eventually it'll all come down to different aspects of strengthening the cardiac surgical system, but obviously the surgical workforce is a really key and perhaps the most key part of it.
Sure. So when you finally are able to enter the clinical portion of your career, how do you envision this effort that you're headlining here will change when you're able to actually be on the ground and sort of see these issues firsthand? And do you anticipate what that will be like for you and how it will change the way you approach this?
Yeah, that's a tough question, and I think something that many trainees who are interested in global health and then are still in clinical training are kind of grappling with. For the sake of my clinical training, I'll obviously try and make sure that I become as clinically good as I can before I enter the actual staff years. But long term, I'm hoping to mostly focus on the policy side of things. Throughout my early academic career, that's been my biggest interest, has been working with ministries of health and working with governments to try and inform health policy, specifically as it relates to surgery and hopefully in the long term related to cardiac surgery, because I strongly believe that having a proper health policy and plan in place that actually integrates cardiac surgery will ultimately ensure that there is sustainability on the ground. And so I'm hoping that, as I gain more clinical experience, that I'm able to kind of relay some of my academic and clinical experiences better through kind of the policy pipeline, so to say, to be able to inform policymakers as well. And hopefully with that, help inform some of the policy plans long term as well.
Well, we can't wait to see it. How would you, last question, how would you advise a younger perhaps trainee or student that wants to kind of follow a pathway like you've navigated here? Where do they start?
Yeah, so I think there's many opportunities to get started. Unfortunately, CTSNet Global has a lot of resources that are open access available. And so whether it's related to webinars or articles, there's many resources that they can look at and kind of get inspired with and get some sense of how to get started. There's more and more institutions in the US and Canada all across the globe that are providing opportunities for residents and med students to get involved in global health or global surgical masters or research programs or fellowships and so forth. I myself have done a year of a global surgery fellowship in the US, and so I can definitely attest to kind of the benefits of getting into a formal program and getting some experience on the ground, but also having a look at many of the NGOs that are working in the field who are not just doing clinical work, but also providing a lot of advocacy and research opportunities. And so I think this is a great time for trainees to get involved in this space. I think there's been tremendous progress over the past 10 years, and I think we'll see that accelerate only further in the next 10.
Fantastic. Well, it's a bright outlook then for our efforts together, right? Fantastic. Thanks for joining us.
Thank you for having me.
Great.